Respiratory symptoms. Most of you who are currently doing general nursing practice would have come across at least a few of the symptoms that we'll be discussing today. It's a pretty common occurrence in our daily life, what we come across. At the get go, I'd like to say that respiratory symptoms, the basic skeletal structure behind analyzing and treating it, basically remains the same for basic clinical practice and palliative care. The difference comes in certain subtle changes that we add or change in different steps of the evaluation process and the treating process, and also in the fact that in the overarching theme of palliative care, our primary concern is to do with improving the quality of life of the patient, as opposed to the curative efforts that we see in a day-to-day clinical practice. So these are the common symptoms that we will come across as respiratory symptoms in palliative care. I've listed 5 of these. Of these, today we'll be going through breathlessness, cough, and hiccups. As for hemoptysis and pleural effusion, these are both conditions that require, let's say, a specialist intervention. It has a lot of expertise required in it, and hence I will not be discussing it in too much detail. After the end of the 3 common symptoms that we come across, I'll just mention it in brief. So we'll move on to the first symptom, that is breathlessness. So by definition, breathlessness is it's a subjective experience of breathing discomfort. The word you have to pay attention to is subjective. As with all symptoms, it is what the patient says it is. We have no physical measure to evaluate breathlessness. If the patient says that they're feeling breathless, then that is the measure by which we go with. And it's commonly experienced by the patient as something intermittent. That is, it comes in attacks. You have seen it in public media, in movies and serials, that there are episodes of pain in which they start gasping for air. And typically, these attacks of breathlessness last for a few minutes, maybe 5 to 15 minutes. And they are usually preceded by something. It may either be physical activity, exertion. It can be anxiety attacks, panic attacks that will lead to this breathlessness. It can be something as simple as just bending over to pick something up, bending over to tie their shoelace or stuff like that. That can also precipitate breathlessness. And in cases that we deal with, cancer patients and patients who have long-term chronic illnesses, something as simple as prolonged talking can also lead to breathing difficulty. And the impact that this has on their daily life is that, one, they have breathlessness, so most of their daily life activities will be restricted. If there are people who have like really severe breathlessness, they will be so hard pressed to do most of their daily activities, including just getting up from bed and going to the bathroom. So stuff like that will be severely restricted, and that in turn will lead to social restrictions. They will not be able to move about and interact with their family, with their friends, leading to a loss of independence and a sense of isolation, which in turn leads to frustration, depression, anger outbursts, stuff like that. So that is the uh, let's say the crux of the problem that it forms to the patient. Also, while the while a person has breathlessness, it's not like they're calm. It's always associated with the sense of fear. Uh, Once you stop getting enough air, once you feel breathless, the only response is to feel fear. They panic. So that is the let's say the what you see from outside when you're looking at a patient who is having breathlessness. So this is the basic underlying things that are going on. Moving to the next slide. The occurrence of breathlessness in the caseload that we see, basically, primarily in lung cancer, almost 50% of patients have been shown to have breathlessness. And this can either be due to basically the presence of a mass lesion in the lung, or due to the weakness of the respiratory muscles, that is something to do with prolonged bed rest and decreased activity. It is also present in other chronic conditions. Specifically speaking, you can look at the respiratory conditions like COPD and asthma, in which basically it's a respiratory disease. So 90 to 95% of patients will have breathlessness. Then heart diseases, in 60 to 90% of cases, there will be breathlessness. And also renal conditions. CKD patients can have pulmonary edema, and that can lead to breathlessness. And AIDS, they are immunocompromised. They can have multiple infections leading to breathlessness. And the incidence is around 10 to 60%. And as death draws near, as the end of life is approaching, the incidence of breathlessness goes up. And in cancer patients, almost 70% of our patients tends to have breathlessness in the towards the last week of life. And one thing you do have to note about breathlessness is that it is an independent predictor of survival. I don't know if the performance status scale was discussed earlier. Basically, we have predictors for prognosis that is based on the symptomatology, their activity, how long the patient is expected to survive. It is basically an indicator with which we can plan for the further management. And second to that, breathlessness tends to be the next most important predictor of prognostic criteria. So these are some of the causes of that tends to be quite a long list of causes of breathlessness, but some of them have been mentioned here. They include anemia, known breathless conditions such as asthma, atelectasis, which is collapse of the lung, cancer, again COPD, which is again a breathing difficulty condition, empyema, heart failure, pneumonia, pneumothorax, PE. And one thing to note here is the treatment-induced part, because in our cases, we tend to have maybe as compared to the general population, we tend to see a lot of cancer patients. So chemotherapy-induced and radiotherapy-induced changes to the lung is also a known case of breathlessness in our clinical practice. This can include chemotherapy-induced pneumonitis, fibrosis, or chemotherapy-induced cardiomyopathy. Also, pneumonectomy in lung cancer patients. If surgery is a feasible option, then they will remove the lobe of lung which is affected, and that is called pneumonectomy. And that decrease in lung volume will be a cause of breathlessness. Then definitely there are psychological aspects of it. Anxiety, panic attacks, that can lead to episodes of breathlessness, which is called hyperventilation. We'll deal with it. And definitely depression is also a cause of breathlessness. And I had mentioned cancer as a cause of breathlessness before. And within cancer, how does cancer as a disease cause breathlessness? That is what has been listed. So, first and foremost, abdominal distension. If there is, let's say, an abdominal malignancy, it is going to form a very huge mass in the abdomen. And if there's a mass in the abdomen, the diaphragm which lies above, it cannot come down so that we can breathe in air. So that will be a cause. Definitely, if there is fluid, same reason as a mass, the diaphragm cannot come down and be breathless. Cachexia, that is wasting. The muscles, they'll undergo wasting and become weak, including the respiratory muscles, the diaphragm. So that can lead to breathlessness. Then there are a lot of metastatic events that have been described here, including large area obstruction, cardiac mets, lymphangitis, etc. And definitely these are again pericardial effusion, phrenic nerve palsy. All of these are to do with the metastasis from the primary cancer involving either the cardiac structures and neural structures or the pleura, stuff like that, that can lead to breathing difficulty. So these are the specific causes secondary to cancer that will lead to breathlessness. So we know what breathlessness is, and we discuss some of the causes also. Next, we start off with the actual clinical practice of it. And this is where I said that there is a very significant overlap between the structure in which the basic framework by which we deal with the patient. The thing is, first and foremost, you see a patient, and what we do is we take the history. In the history, what all should come. That is where the finer details comes into play. That is where palliative care tends to differ from our baseline clinical practice. So, first and foremost, you ask what? When did it start? Since how long have you been having breathlessness? How did it start? Did it start over a course of minutes? Did it take hours? Did it take weeks? Did it take months? That is, was it an acute onset? Was it a subacute onset? Or is it a chronic breathlessness? That is what we have to know. Next, what is it associated with? Is the breathlessness associated with fever? Is it associated with cough? Is it associated with blood and cough, hemoptysis? Is there production of sputum with it? Is there audible wheeze? Is there stridor? You have to ask the associated symptoms. And does doing anything make it better? That is exacerbating factors. And does doing anything make it worse? That is relieving factors. All of these come in the basic history taking of any symptom. That is why there is an overlap with the usual clinical picture. And then I had mentioned that one of the causes of breathlessness being anxiety. So that is where this comes in. That is any symptoms that are suggestive of hyperventilation. Hyperventilation is shallow, rapid breathing. That is, instead of taking a deep breath inside, the patient tends to take shallow, deep breaths. So what happens there is not enough oxygenation. It's really shallow. There's not enough breath actually reaching there that can be used for actual gaseous exchange. And that tends to happen in episodes of panic attacks. Generally speaking, they tend to occur with panic attacks. So feature suggestive of this will be one, definitely the patient may have a history of panic attacks in the past. Okay, that is a definite red flag that will point to it. The other thing is there will be a poor relationship of dyspnea to exertion. That is, in patients who have breathlessness due to hyperventilation, the episodes of breathlessness tend to not be related to any physical activity whatsoever. Usually, the classical picture tends to be that once they walk or do some physical activity or on long talking, they had breathlessness. That won't be present in hyperventilation. Then also there is fluctuating breathlessness. Usually we expect a chronic breathlessness case or due to some serious illness, it tends to be a long course with gradual progression. That is, it tends to get worse over time. But in hyperventilation, the situation tends to be that at some points they have definite breathlessness. At some points they're okay, and then again they get breathless. So it's a fluctuating course. And if that is present in the history, then that also points towards hyperventilation. And also the breathlessness will be associated with social situations. If the situation is stressful, say maybe a public gathering or stuff like that, and they have anxiety, and that precipitates breathlessness based on where they are and who they are surrounded with. On their social situation, if they have breathlessness varying with that, then that also points towards hyperventilation. And an important question to ask in the past is the treatment history, specifically their medical and treatment history, whether they have had any previous episodes of cardiac issues. Again, cardiac causes are a very important part of, they form a very core problem causing breathlessness, and also the drug history. Any drugs that they may have taken for any other disease that may have led to breathlessness. And the things I mentioned just before this, all of that is basically common to any clinical practice. That is, a patient comes to you with symptoms. In general practice, this is what you ask on a regular basis. These are the points where palliative care differs. First is because in palliative care, and it's supposed to be in general, but in palliative care, we pay specific attention to the fact that we treat the patient, we make them comfortable and not just treat the disease. So that is where these comes in. First is assess the level of independence. That is, instead of just asking the patient, are you breathless? To which the answer is either yes or no. It's closed tent. They cannot tell you anything further. That just tells you whether she has breathlessness or not, which ideally you can already observe. So those closed end questions, those tend to be not the way forward for us to actually understand what is bothering the patient. So what we do is, what has the breathlessness done to you? How has it affected your life? Those are open-ended questions so that the patient gets to describe what the actual symptom has done to them with respect to their daily livelihood. So for instance, are they currently able to care for themselves? After the breathlessness started, have they been able to go to the bathroom by themselves? Has going to such a small distance, going to the dining room to have food, going to the bathroom, has that been, have they been unable to do it in the past few days of breathlessness? And what they have been doing to cope with it? And what does it mean to the patient? That is, what have they understood regarding this? And how they feel when they feel breathless. As I said, during an episode of breathlessness, it's not a pleasant experience. You're not getting enough air and they tend to panic. It will be so severe that the patient can actually feel a sense of impending death. They feel that they're dying with every episode of breathlessness, and it's important to assess that. This, even though it comes in history, it also forms a part of the management that we'll get to in further slides. And this is what I mentioned earlier, a detailed evaluation of the patient's knowledge, that is what they know about the breathlessness. How do they know what it has been caused by? Do they know what it entails and what is to come in the future? And what they have, whatever their beliefs is regarding medicines, regarding treatment procedures, regarding life in general, and their behavioral patterns also. Do they have anger outbursts? Do they have panic attacks? All of these stuff we have to evaluate because this forms a very big part of the pharmacological aspect of the management aspect that I'll be discussing later. And all of this has to be included in the history. And this is where palliative care has differed from the usual clinical history taking where there is simply symptom assessment. This is you look at the patient as a whole. So you saw the patient, you've taken the history, including their psychosocial evaluation to understand what it has done to them. Next step, obviously, is to examine the patient. Examination, in this, I've only written central sinus, but definitely the vitals matter. The patient is breathless, so you take a look at the respiratory rate. If they're tachypneic, that is, if there's a respiratory rate in adults, it's in males, it's 14 to 18. In females, it's 12 to 16 per minute. That is the normal range of respiration that we look for. Anything above that is considered to be a higher rate, that is tachypnea. So you look for tachypnea. You look at the pulse rate because one of the causes that we had mentioned for breathlessness was anemia. And in anemic patients, there tends to be tachycardia. Heart rate of 60 to 100 is considered to be normal. Anything above 100 is considered to be tachycardia. So both of these can point towards that they are positive clinical findings in a case of breathlessness. Also, we can look at, we can ask them to simulate hyperventilation. We can ask them to take shallow, rapid breathing. And if that precipitates their episodes of reproduces the symptoms of breathlessness that they describe, then it is hyperventilation. This is what you can look for with examination. So you took the history, you have examined them, you checked the vitals and everything, and next step is to investigate. So as far as investigations goes, the advantage of, let's say, an advantage of palliative medicine is most of the patients who come to us tend to already have a diagnosis in hand. So investigations don't form a huge part of our clinical practice. But in case there is a new onset breathlessness in a patient who comes to us, we will definitely have to investigate to maybe find out correctable causes. And the common investigation that we can do are one is definitely a CBC. That could be an infection that is causing the breathlessness. For a CBC, we can look at the total count. There can be anemia causing breathlessness, hence the hemoglobin. We can take a chest X-ray to look for any physical changes there, look for pleural effusion. Any changes to the lung parenchyma can be noted in the chest X-ray. Excuse me. The next is oxygen saturation measurement. We measure oxygen saturation on a regular basis in a tertiary care hospital. It's a part of a routine clinical examination of a patient. In fact, if you go to a casualty in a tertiary care hospital, it is included among the vitals. They do put a pulse oximeter and check your oxygen saturation as well. But it does not play such an important role in palliative medicine. The only role it tends to play is to decide whether to use oxygen or not. Other than that, the patient is breathless. There is not much meaning in us knowing the oxygen saturation value as such. It's only when you have to decide on whether oxygen support will be beneficial or not, whether it's required or not, then we can maybe take a look at the oxygen saturation. Also, to rule out cardiac causes, we can definitely go for an ECG. We can suggest an echo. And in case emboli are suspected, CTPA, which is CT pulmonary angiogram, it's a scan to look for vascular anomalies that can be done. These are all ideally restricted to specialists who actually are undergoing trying curative efforts. We can look for the baseline values and definitely the correctable causes can be corrected. The rest we can definitely leave up to the specialist if and so if proves to be beneficial to the patient. So we have investigated and we've got a definite answer as to why the patient has breathlessness. So now we have to actually manage it. For the purpose of management, we have classified breathlessness into three categories. This is just for practical purposes as to how we will treat the patient. And these three categories are whether the breathlessness for the patient is present during exertion only, that is, their finite rest, just when they get up to do something, when they do some activity, they have breathlessness. That is first category. The second category is they are doing nothing. They're just sitting down, they're just lying down, and even at that position, they are having breathlessness. That is category 2. And the third is terminal. That is the breathlessness that people tend to have towards the end of life. These are the three practical categories that we use to guide our management practices. This is a table that is seen in one of our palliative care textbooks. This shows the percentage of let's say, the contribution of the three different forms of treatment that I'm pretty sure has been discussed throughout the course. That is, we have basically three criteria of treatment modalities that we use. That is, first is we always correct the correctable. That is the purpose of the investigations that we probably have done for a particular patient, and the correctable causes are being treated. That is the first step. Second is the non-pharmacological management that we can use. That is, anything other than the drugs that we use will come under this category. And the third is definitely giving drugs. That is symptomatic drug treatment. And all three play a different percentage role in the three categories that we have described. So you can see as in the photo, the first segment, that is the first category, that is breathlessness only felt on exertion. In that, we see that it's an equal part, almost an equal part of correcting the correctable causes, also the non-pharmacological approach. The actual drug therapy of it only plays a very minimal role. And moving to the second round, we see that the importance of correcting the correctable causes and the non-pharmacological management has come down, and there has been an increasing importance of giving drugs. That is, when there is breathlessness at rest. And towards the end of the category, when we go to category 3, that is terminal delirium, there is very little that we can do in way of correcting the correctable, which may only provide some relief. There's also some role for giving non-pharmacological management, but primarily the treatment, the symptom management will be based on drug therapy for terminal breathlessness. So the first category, that is correcting the correctable. So this is the reason why we did the investigations. We have looked for infection with CBC. We have looked for anemia with HP, CT, X-ray, etc. ECG for cardiac issues, and we have identified some complaint, some condition that is causing breathlessness to the patient at this point. And in this step, we correct those. This would involve medicines. Basically, it's that chronic condition aside, there's something else that has come up that is causing breathlessness, and that is what we address here. So if it's a respiratory infection that is causing that, we found out with the CBC, definitely give antibiotics. If it's a viral infection, give antivirals. If it's COPD or asthma exacerbation, they have a long-term history of a breathing issue, and now they have an exacerbation of asthma or COPD. We give symptomatic management. You can give inhalers, you can give nebulizations for those. If it's hypoxia, if it's an acute shortage of oxygen that is causing it, definitely oxygen therapy can help, may help. If it's an obstruction of the trachea or the bronchus, which is maybe secondary to the cancer, then maybe surgery can be indicated, maybe an endoscopy and a removal, or maybe targeted radiotherapy or chemo can be indicated. This is all based on the actual treatment that is feasible to the patient at that point of time. And again, pleural effusion, ascites, these, if you tap the pleural effusion, if you tap the ascites, there will be a definite improvement in the breathing status of the patient. So you have found something out via investigations, via history, and then you have treated that particular cause, which may lead to a relief in breathlessness. That is the first step. Second step is the non-pharmacological management, which will form a huge crux of the medical practice that we do in palliative care. This is more important than, I dare say, more important than the correcting the correctable, and has almost as much importance as giving them drugs. Definitely in the first two categories, it's if not equally important, it's more important. So, and also this tends to be the very first things that you can do for the patient when they have breathlessness, and it's what you can train them to do. This is what will most probably provide them with quite a lot of improvement in their quality of life. It is what will provide them with a bit more confidence also. So, and it has the following components. The first one is what we were supposed to do during the history taking. That is exploring the patient's insight. That is what we mentioned, the history taking. I told you that will be also of use in the treatment part also. That is, we'll go into detail in the next slides. Second is maximizing the feeling of control over breathlessness. Again, all of these are points which will be described in detail. Third is maximizing the functional ability. And fourth is to reduce feelings of personal and social isolation. So we'll be looking at each of this in detail. First, exploring the insight. We took a look at it during the history taking, but again, I'll just repeat it again. What is the meaning of breathlessness to the patient and the caregivers? What has it done to them? What do they understand from it? What do they understand the cause of it to be? Where do they expect it to go? Here, what you do is you know the history, you know what the patient has understood about the breathlessness. They have some beliefs in them. Okay. Whatever it is, we have explored it. We have asked them what it means, and they've told it to us. And this actually takes a bit of rapport building also on your part. You have asked them, and they've actually opened up to you what is bothering them. And some of these may include fear of sudden death. They believe that, okay, I am having episodes of breathlessness. At any such episode, I may die. Okay. And they're unsure as to what makes them be breathless. They are not aware. They just feel breathless. So they may think, okay, I have to stay in bed all the time. Otherwise, if I get up, I'll get breathlessness. If I go to the bathroom, I'll get breathlessness. So that is definitely something we have to keep in mind. That is something you take history wise, and what you do is you start addressing each and every one of them. This is where communication comes into play. You have to definitely build a rapport with your patient. They have to be comfortable opening up to you so that they can express whatever is troubling them in their mind to you, and they have to trust you enough so that the advice that you give them, that they will actually try to follow it. And this is not going to happen with one session. The thing is, it takes repeated communication so that they open up to you, and also a repeated counseling so that they tend to follow what you say. So, and what can help in these situations is basically we explain it to them. If the situation calls for it, if they are agreeing to it, you can definitely talk about the diagnosis, whatever it is. You can explain it to them in whatever detail that they want to understand it from. You can state that what is likely to happen and what is not likely to happen. For example, as we said, there's a fear of sudden death with breathlessness. You can say that breathlessness by itself is not fatal. Just because she or he has one episode of breathlessness does not mean they are going to die suddenly. Okay. That you have to explain to them, you have to stress it to them so that they understand. You can address concerns such as whether I'll get breathlessness if I get up. So stuff like that you have to address. Also, this is the step where you make plans, because in palliative care these are long-term chronic illnesses, and some of them are terminal and some of them will gradually worsen over time. So it is in this step where you make plans for the future. Once the explanation is over, once the concerns are addressed and they understand what is happening, then the next step would be to make the plan for the future. As in the breathlessness, it may get worse over time. As the time goes on, the episodes, the frequency of the attacks may increase, the severity of the attacks may increase, and what we will do then, what we can do so that even if such attacks comes, we can try and keep you as comfortable as possible. That does the planning can also be done in this state, and that forms a that goes a very long way in providing some amount of confidence to the patient. They know, they are aware of what is happening, they have the knowledge, so that the next time it comes up, they won't have as much fear, they won't panic as much, they won't fear for their life as much. Definitely, in this case, you can also help cope with the loss of role. That is, if there is, let's say, if it was a father in a family who has been afflicted with breathlessness, and currently he's not able to take care of his family in the traditional sense. In that case, definitely some counseling may help. We can actually help him understand that that's part of the disease progress and it's nothing to be ashamed of, and that asking for help and letting his family take care of him is not too bad. And the loss of abilities, that we can try and keep him comfortable and try and at least get him back to at least doing some of his daily activities, that can also be counseled in this stage. So that is regarding exploring insight. Second stage was giving them, maximizing a feeling of control. What does this mean? The thing is, during breathlessness, an episode, an acute attack of breathlessness, uh, what I mentioned was there is a feeling of fear, of panic. You're no longer in control. Once you stop getting enough oxygen, there is no air going into your lungs. It's a feeling of utter panic and disorder. You have no control over what happens. You're panicking, running all around the place. What you have to do is try and introduce some amount of control over this scenario so that their next episode, when it comes, they have a sense that they are the one in control and it's not the breathlessness that's making them run all over the place. And this, again, it's not going to happen overnight, because this is essentially what we'll be doing is we are trying to teach them to breathe again. Yet learning, making them learn how to breathe consciously so that the next time they feel breathless, they don't panic as much. And this is going to take time. So this will again take repeated sessions in which you counsel them, in which you train them. And basically, the crux of the issue is that in breathlessness, the breathing tends to be rapid and shallow, and this is not ideal for actually air intake. So what we have to do is we have to encourage the patient to take normal breaths. And how to do this is, uh, if you are breathless, you tend to tense up, the body is clenched. So what we ask them is to relax the neck, relax the shoulders, and relax the upper chest. This is very easy to say, but to actually make it practicable, that is what is the challenge, because from outside we can tell the patient, okay, you relax, but that is not what they're going to be going through. So that is why I said this takes repeated attempts and repeated training. And if we are able to make this work, then that is, it helps in minimizing the work of breathing, the amount of energy that the patient will have to spend on trying to breathe then. Also, because they know something, okay, I am having breathlessness and this is what they've told me to do, they get the feeling that they are in control of the situation. And usually, this breathing exercise, the training that we do, it is usually used so that they can recover from an episode of breathlessness. And again, as I said, it takes a lot of training, and we ask them to do this breathing exercise for at least 10 minutes each day, which will help with recall. That is, by repetition, they learn to do it on a impulse basis. Even if they have breathlessness, they'll be able to do with a 10-minute practice each day. And as to how we do it, it's right. It can be taught with 3 R's: rise, relax, and rest. Okay. So first is rise. First thing you asked is ask them to relax their upper chest, the neck, the shoulders, and the chest. Next is rise, because the air will go in by default. So you let your abdomen rise. When you breathe in, you have noticed that both the chest goes up and your abdomen goes out. Also, it rises. So let it rise. Do not clench. Do not actually pull your muscles up and resist it. Just let it rise accordingly as the breath goes in. Next, second step is relax. You don't have to force the breath out. Just relax the tummy, like let it come back. Don't cleanse it, and the breath will go out on its own. That is the second step. You let it go in on its own without contracting your abdomen, so that it rose up on its own. You relax so that it goes back out. Next is rest. Don't go for an immediate next breath. Let it come naturally. You take a break, and when the body wants it, the next breath will go in. That is relax. You ask them to take a gentle breath in and don't do anything, let it flow out naturally. And then in between, a pause. This pause is natural until the body actually requires the next breath. And this is what you ask them to repeat for at least 10 minutes. That is, be conscious of your own breathing, something that we used to do involuntarily on a daily basis. You ask them to be conscious of it and do every step deliberately, so that when the time comes, they will be able to do it on their own. So these are the 3 steps that we teach them. There is a certain modification that we can make in specific cases, and one is COPD. COPD has two components. One is chronic bronchitis, the other is emphysema. Emphysema specifically means it's a irreversible dilatation of the airways, or specifically the terminal airways. And that means in COPD specifically, there is a condition in which there is hyperinflation of the lung. That is, if let's say one lung is supposed to be, let's say, this big during, this is basically just in a simple way, it's this big, it tends to be this big. That is hyperinflation. It's more inflated than it needs to be. So in such COPD cases, what we can advise is, we mentioned, first was rise and relax. In the relaxed state, where they were supposed to breathe out naturally, let the air flow out, we ask them to purse their lips. That is, so that the outer airflow, what goes out, it just has a small amount of resistance, so that the hyperinflation is not as severe in COPD. And the other issue is, with this breathing training, is that breathing control is not suitable for patients whose lungs are already hyperinflated, because we depend on the diaphragm being completely healthy so that the actual breathing actually happens. The issue is in hyperinflation, the diaphragm, which is a dome-shaped structure, that is flattened. Flattened is the thing that should supposed to happen to the diaphragm when we take breaths in. But in these cases, because the lung is hyperinflated, it's already flattened. So in such patients, the breathing control exercise may not provide so much relief. Next is we taught them how to breathe. That is, we taught them how to breathe consciously. Next is we can advise certain positions to them that may provide them with some relief based on their underlying condition. So again, the first condition will be looking at a COPD. It's very prevalent because quite a lot of our population are smokers. So COPD is a very prevalent condition here. What we can ask them to do, and most of these positioning things, these patients tend to do on reflex. We don't actually have to teach it to them. They tend to find out whichever position they are comfortable in by their own. But in case they don't, we can definitely ask them to do it so that they feel a bit better. So first is COPD. What we can ask them is to lean forwards, basically with their arms and elbows resting in front. Basically, they can put their knees up and rest their arms on it or on a table. They can lean forwards, and this, what it does is it clenches, it contracts your abdomen so that there is more pressure in your stomach. And this will push air out. You see, the pressure there coming from the abdomen and from the chest due to leaning forwards, this will aid in the actual air that has gone in to go out, because in COPD, there is hyperinflation involved. So this contracted position where you bend forwards, that will allow easier breathing. Then, in unilateral conditions in which only one side is affected, which can either be a bronchopulmonary disease such as a collapse, consolidation due to pneumonia, or a pleural effusion, what we can ask them to do is to lie on the normal side. If suppose I have a disease and it's on the right side, what I should do is lie on my left side. What this does is there is a thing called ventilation perfusion ratio. It is a concept where there are three zones. I'm not going to get into detail. This ventilation perfusion ratio matching, if it is perfectly matched, it allows for better efficiency of air exchange. So if you make the patient lie down on the normal side, that makes sure that whatever air exchange is going on in the lungs, that is more efficient. And basically, if you see patients who are using accessory muscles of respiration, you see their necks tensing, you see there is chest indrawing, stuff like that. The accessory muscles are being used. Definitely bracing of the arms. You ask them to hold on to something, place the arms by their hips, use something so that the shoulder girdle, the shoulder joints on both sides are stable, so that the muscles that are actually acting along with the diaphragm, they get a stable portion to hold on to. That is something we can advise in case we see that the patient is using accessory muscles of respiration, which again, you notice by the clenching of the neck, intercostal indrawing, stuff like that. If you notice it, you can ask them to brace the arms while they are having episodes of breathlessness. Third one is during an episode of breathlessness, you can definitely use an electric fan. This is, it can be basically a table fan or maybe even a handheld fan. A cold air can be blown directly towards their face, particularly towards their nose and mouth. Wherever the air goes in, you direct the airflow towards there. This can be done by placing a fan maybe 15, 20 centimeters away from their face. And that itself will provide them with quite a lot of relief. We've seen it in our patients, we've seen it in our wards. This simple procedure of just placing a fan by their face so that cool air is being blown towards them, that will provide quite a lot of relief. And the physiology behind this, it's thought to be because there are basically cold sensitive receptors by the facial nerve and the in the nasopharyngeal membranes that cause some physiological changes from bronchodilation that can lead to some relief in breathlessness. So the use of an electric fan, even though it seems so simple, it provides quite a lot of relief for most of our patients. Okay, so that was regarding maximizing the patient's control of the situation. Those were, we taught them how to breathe, we taught them how to position themselves, and we stressed on the importance of using a fan, basically, to provide some relief. Next is functional ability, what they were able to do in their life. Okay, they have had onset of breathlessness, and following that, they have lost a lot of that ability to function in life as an individual. And this is called the breathing, thinking, and functioning model. This shows a vicious cycle in which breathlessness causes something which in turn worsens breathlessness. So We have three criteria here, that is breathing, thinking, and functioning. You can take a look at any of these loops. First, let's take a look at breathing. The patient has breathlessness, and as a result of the decreased oxygen intake of breathlessness, they have an increased respiratory rate. And for the increased respiratory rate, they'll use their accessory muscles. And because of the use of accessory muscles, there will be hyperinflation of the lungs. And because the tachypnea, the rapid breathing, it's inefficient, as we mentioned, because it is shallow and it is too fast. The patient won't get enough oxygen. So what does that make it? It makes it so that the breathlessness worsens. And again, the cycle continues. Because the breathlessness worsens, again, the respiratory rate increases. The increased respiratory rate is again, it is worse. It's even shallower. It leads to more respiratory distress. Thinking. So the patient is having, let's say, a bad diagnosis, and also they are having chronic breathlessness, they are having acute attacks of breathlessness, and they are thinking, okay, this may lead to my death. So they think about dying, and they pay undue attention. We normally don't mind our breathing. It's something that happens in the background. But because they have had such episodes of breathlessness, they keep a very close eye. They notice it abnormally that they are breathing, and then they also think about their past experience. Okay, last time I had breathlessness, it was so bad. I almost died. So that keeps replaying in their minds. They're very aware about it. And that leads to anxiety. And as we mentioned, anxiety is a cause for breathlessness. And then they have another episode. Again, they think about it. They again have anxiety. They again have breathlessness. Again, a vicious cycle. Third is functioning. A patient started having breathlessness. And because this patient has breathlessness, we have asked them to take rest. I, one of my family members has breathlessness. So because they are breathless, I tell them you take rest. What happens when they take rest? One is once they were doing activity, their muscles were being used. They were extremely active, and I have told them, okay, you lie down on a bed. You don't move from there. Over time, what happens is their muscles start to get weak because without use, the muscles weaken definitely over time. And when the muscles weaken, the respiratory muscles will also get weak. And if the respiratory muscles are weak, the breathlessness worsens. And the breathlessness worsens. So what do? You ask them to take more rest. And more rest leads to more weakness, leads to more breathlessness. Again, a vicious cycle. So this is what you have to keep in mind is what's going on underneath and what you have to address here. Next slide. So this is what I explained earlier. So what we have to know from this is that the physical activity aspect of it plays a huge role in breathlessness. If you ask them to continue with rest, the problem is it's only going to make things worse. So regular activity and exercise is indicated in cases of patients with breathlessness. Never mind the fact that if they move, they have breathlessness. It does not mean that we have to tell them to stay in bed. We have to tell them to take rest. Okay, we can definitely advise them to do some physical activity. Okay, we have to explain to them the importance of maintaining some activity so that the muscles don't weaken. Also, the fact that these doing some activities will make them think about something else other than the fact that they have breathlessness. So that if they actually are doing something, they are thinking about that instead of thinking about the breathlessness, making it worse. Also, the activity suggested, it should be according to the patient. It's not like a patient who was in basically in an elder who is just barely able to walk. The next day you're saying, okay, it's physical activity is required, go run 100 meters. That is not what you do. You look at them based on their present clinical scenario, based on their general condition. You start advising small amounts of daily activities. It can be anything. You start off small and then you increment, you increase it gradually. It can be anything as simple as the patient who is lying down and is currently breathless. You ask them to talk. You ask them to sit up first, maybe for a short period at a time, which you gradually increase. As the muscles tend to act more, you can gradually increase it, and then small increments of movements can be suggested. This definitely has to be tailored according to the patient and according to their general status. As I mentioned, make the patient do what they're able to do, nothing more, nothing less. And the last step in non-pharmacological treatment was to avoid isolation. Isolation has to do with basically the one of the vicious cycles that we saw. If you stay alone, you are alone with your thoughts. If there is someone breathless and you ask them to stay in bed and you put them in a room, you give them their food, you give them their water there, you give them a catheter so that they don't have to walk. We put diapers so that they don't have to walk to the bathroom. They are completely confined to the room. And then the rest of the family, they spend their time eating lunch in the dining room. They walk around, they do everything else. But this is all done with a good intention so that the patient does not move and worsens their breathlessness. This is all being done with good intentions. But the fact is that leads to isolation. Again, that leads to anxiety, that leads to depression. And all of these social aspects, these psychological aspects will lead to a worsening state. So what is important is to counsel the family members to make sure that the patient in question does not become isolated from their family. There has to be open communication. They have to spend time with the patient. And in the previous step, we are trying to make them more active, and that can also play a role in improving this. So that was the non-pharmacological management that we can do. And all of those steps that we mentioned so far, though they will go a very long way in managing quite a lot of the concerns that most of your patients that you'll come across see. And after this comes the role of actually giving them drugs. This is basically, it plays a supporting role to the non-pharmacological aspects that we saw. We've made them sit up, the activities have started, and the breathlessness that is there that will not go with the pharmacological things. The breathlessness is actually caused due to the underlying disease. For that, we give the drugs. So breathlessness, definitely. If you go to a hospital, you see you're breathless, what they're going to give you is an nebulization with a bronchodilator or a steroid. That is what happens on a daily basis, and definitely it's of use here also. We can try bronchodilators. Specifically, we can try a trial, maybe give a short-acting beta agonist, a bronchodilator for a few weeks as an inhaler, and see what happens. The specific recommendation that is given is to use a short-acting bronchodilator. A beta-2 agonist that can be used that acts for a very short period of time, and we advise them to use it prior to any exertion. If the patient is, suppose they get breathless while they're walking, what they tell them is, when you're sitting down, take your inhaler, take a puff, and then start walking. Okay, so that the actual episode of breathlessness does not occur. We ask them to actually take a bronchodilator prior to that. And then there's also the use of bronchodilators in the last few weeks of life. Definitely the use of short-acting nebulized, basically, instead of the inhalers, you can use nebulization masks. These are preferred in the last weeks of life, but the use of that, we'll see as we come to it. We'll see the use of that. Next, opioids. This is where palliative care tends to veer off from the normal clinical practice because we are taught that opioids cause respiratory depression. That is, the patient has breathlessness, and what you're doing is sending them into more respiratory distress. This is what comes to your mind when you think about using opioids in breathlessness. But the fact of the matter is, if the conventional medicines fail to control breathlessness, you gave them beta agonists, you gave them steroids, nothing has provided them with adequate relief. Definitely opioids are on the table because respiratory depression is basically losing the respiratory drive. Suppose the patient is having breathlessness, their respiratory rate is at around, let's say, 30, 40. You give an opioid. What it does is it reduces the respiratory rate. It causes respiratory depression and it comes back down to, let's say, 20. So what does that do for the patient? What the patient feels is that has come down. That rapid breathing, that has gone down. So for the patient, even though we have done, the opioid has done literally nothing to actually address the reduction in oxygen in the body, it is still providing them with comfort so that they don't feel as breathless. They don't feel as breathless. So how it acts? Basically, in our body, when there's a buildup of carbon dioxide, when there's a reduction in oxygen, there's an increase in carbon dioxide. Then there's a center in our brain that tells our body, take in breaths. That is, there's a normal level, you increase that rate. That is what the brain tells when there's increased carbon dioxide. What morphine does is it tells the center, don't. It's okay, let it be. That increased rate, what it does, That impulse is blocked by opioids. And that again, I maintain this is for some patient whose breathing rate is very high. And because of the fact that we give opioids, it won't go down all the way to zero. It won't go down to single digits. It brings it down just enough so that they don't feel that sensation of having extremely high rate of respiration. That is the helpful thing that opioid does. And the uses, currently we have 10 and 20 milligram tablets available, at least in our facility. And what we can use is use a quarter or a half tablet. Initially, you start it off as a rescue dose. We tell them, we tell the caregivers, we tell the patient, when you are having breathlessness, you take a quarter tablet or you take half a tablet, and then you assess. If the patient regularly requires at least 2 doses per day, then what we can do is instead of rescue dose, you regularize the dose of morphine. You tell them take a quarter tablet twice daily, or you take a half tablet twice daily, and then you titrate it accordingly. You can either increase the frequency, that is from twice daily, you can go to thrice daily, 4 times daily, 6th hourly, 8th hourly, and maybe 4th hourly, you can go up to that, or you can increase the dose also. Typically, based on the degree of breathlessness, the normal range, that is typically what will be required, goes up to 20 to 60 milligram in 24 hours. This is a divided doses, not a single bolus dose. That was in patients for which opioid was started purely for the function of decreasing their breathlessness. Suppose the patient is already on morphine. They had some amount of pain, and for the pain, we had started them on morphine. In such cases, what we have to do is based on how breathless the patient is. The scoring system, I think you have been taught about it in pain management. It is to assess the severity. It's a numerical rating scale that the patient can express. So what you ask is how severe it is. If the patient describes breathlessness as severe, the score of more than 7 out of 10, 7, 8, 9, or 10, then what is required is suppose the patient is taking 10 milligram of morphine 4th hourly. They're taking one tablet every 4 hours for their pain. And now they report that they have a breathlessness and it is very severe with a score of more than 7 out of 10. What you do is you will have to double the dose of oral morphine. They were taking 10 milligram. What will be required to manage both the pain and the breathlessness is double the dose. 100% more is 20 milligram of morphine every 4 hours will be required. Suppose they say that it's moderate, its pain score is 4, 5, or 6 out of 10. Then the increment over what is already being taken is 50 to 100%. So suppose they are taking, let's say, 10 milligram again, 4th hourly they have been taking. What you have to do is 50% increase. You give 15 milligram 4th hourly, and that is supposed to be enough to manage both the pain and breathlessness. If it's mild, it's 25 to 50%. So 12.5 milligram. If it was 10, you go up to 12.5. And then you have to titrate it as necessary. This is always the first step. Going forwards, you may have to increase or decrease as the patient responds. Specifically, that was in basically malignant cases because we usually tend to reserve opioids until the breathlessness is intractable in case of non-cancer breathlessness. So in COPD, in case all the other treatments fail, definitely morphine opioids are on the table. So in COPD specifically, it's a non-cancer condition. We can start off with just 1 milligram of morphine twice daily. Basically, we can increase it up to basically 1 to 2.5, or a tablet up to 4 times a day over the period of a week. So you take a few days, 48 hours between increasing the dose, and you gradually titrate it up all the way up to 2.5 milligram 4th hour. This is over the course of a week. And then again, you can increase the dose of morphine as required as the patient feels symptomatic relief. Okay, and this is going to be contentious. Oxygen therapy, because uh, our general practice, general nursing practice, general physician practice, general doctor practice, whatever it is, if a patient complains of breathlessness, our response tends to be give them oxygen, put a mask, keep it on top of their face, and maybe they'll feel better. That is the almost it's a reflex for us from basically medical school, nursing school. Wherever you start, if the patient is breathless, you give them oxygen. That is the thing that it's almost written. But what studies say is, if it's a chronic breathlessness, there seems to be no additional benefit to actually giving them oxygen via mask or nasal bronchs. There is, with respect to giving them all the non-pharmacological therapy and the pharmacological therapy that we've discussed so far, the additional benefit of actually giving them air through a mask seems to be negligible. These are based on studies. So, does that mean that we don't use oxygen at all? No. In case it's indicated, if there is actual, this is where the oxygen saturation measurement comes into play. If there is definite severe hypoxemia, that is, you see an oxygen saturation on the probe that shows it's less than 90%, then definitely maybe we can do a trial of oxygen and see if the saturation improves. Also, for patients, maybe they come to you after they visited some other hospital and they tried giving oxygen there, and the patient says that, okay, when I got oxygen, I felt better. And if he's subjectively better, he has significant relief on it, then definitely oxygen is definitely to be considered. But you have to always think twice, because one thing, it is not pleasant to have a mask on your face. It's uncomfortable. It runs over the bridge of your nose. It makes communication very difficult. It makes turning in the bed very difficult. It makes transport very difficult. They can't even walk to the bathroom because they are connected to a cylinder and with a mask to their face. So you have to always consider the distress it may cause to the patient, because the studies show there is no additional benefit. We do give it for patients who actually report benefit, but statistically it's not supposed to. So you weigh the rewards against what that actually provides to you. If you are just giving a mask and it's not giving them any relief, they are still wheezing, and all you're doing is making them uncomfortable, then don't. Okay. The other thing to consider is when death is imminent. We are talking maybe hours to days, and the patient does not have respiratory distress. Towards the end of life, there tends to be gasp. Okay. And basically, here, there is no benefit in giving oxygen. The patient is dying. They will die in the coming hours, they will die in the coming days. So, what benefit does putting a mask on their face give? So, in these cases, even if the probe shows that there is hypoxemia, that's 90, it's 80, is there any benefit in giving oxygen if the patient is going to die a few hours later? No, just don't. And in case the patient has been on oxygen and it has reached a case where they are terminal, they are going to die, there is nothing wrong with removing the oxygen support. Mostly because at that point in their life, there is no benefit being provided by the mask on their face. It's just making it harder to see their face. So keep that in mind. Oxygen is not always the answer. In fact, it's in palliative care, it's rarely the answer. You have to evaluate and act accordingly. And last class of drug that we can use is anxiolytics, because one of the conditions that causes breathlessness was anxiety. The thing is, it's not commonly used, mostly because one, it has no direct effect. The breathing difficulty has to reduce breathlessness. The anxiolytics have no direct effect whatsoever. Also, the fact that if it's anxiety that causes breathlessness, the thing is, you identify, okay, they're anxious, they are having a panic attack. You run to the pharmacy, you load up the medicine, and you come back to actually inject them with it. By that time, generally the anxiety attack has passed. Basically, it's too little, too late. So it's not commonly used. If it's a persisting panic attack, definitely you can try giving it, but more often than not, it's not given, because one, it's not directly acting, and two, most of the time the episode is over. If used, you have to consider how long the prognosis is. If you expect the patient to be alive for less than a month, if it's less than 2 to 4 weeks, then the better option would be to use benzodiazepines, lorazepam or diazepam. If you're giving lorazepam, 0.5 to 1 milligram twice daily can be used. If it's diazepam, that's 2 to 10 milligram at night. And if the prognosis is a bit better, if you are expected to live more than 2 to 4 weeks, then selective serotonin reuptake inhibitors, SSRIs, that is citalopram, escitalopram, can be considered. Specifically, the example given has been citalopram, which can be given as 10 milligram once daily. So that was regarding the management of breathlessness as a complaint. That is a more major respiratory complaint symptom in palliative care. The second one that we are going to move on to is cough. That tends to be I guess this is supposed to be the most common. Breathlessness would come in second, but this is basically considered to be less severe, so that's why it's been placed second. So what is cough? Cough is basically it's a sudden expulsion of air through the large airways. You are basically pushing air out. It's forceful expression. You push air out from your lungs outside. And why is it done? It is done so that in the airways, if there's something that is not supposed to be there, something the body needs to get out, that is what cough does. It forces it out. Air is pushed through the airways so that whatever is causing the irritation, that is also pushed out along with the air and is brought out. Okay. And usually what is attempted to be clear out is foreign matter. It can be something that has been inhaled. It could be dust. It could be secretions. It could be pus due to infection. These are what the body tries to get rid of by coughing. So cough is good. So because it's the body's way of trying to get rid of something that is not supposed to be there. When is it not good? When is it supposed to be considered pathological? When is it a disease? That is when the cough is ineffective. That is, the cough is dry. As I said, cough is supposed to be there to bring something out. And if nothing comes out, that means you're coughing for nothing, and then it becomes pathological. When the cough affects your daily life, you're not able to sleep due to coughing. You're not able to sit because you're coughing. You cough so much that you vomit. If any of these happen, it's causing symptoms. You cough so much that you have chest pain. You fracture your ribs because you cough so much. All of these are grounds to label the cough as being pathological. Okay, and that is when you treat the cough. Next, I told you that the cough is ineffective. How does it become ineffective? That is, when is it a dry cough? There are three major reasons where the cough could be ineffective. First one is decreased expiratory pressure. I told you it's forced expiration through the airways. If the expiratory muscles, the accessory muscles of expiration are weak, then there cannot be enough force to actually push whatever they are trying to push out is going to be. So you are trying to cough, but there is not enough pressure to actually throw stuff out. So that makes it ineffective. And there is mucus in it. Normal mucus, normal cough can bring it out. If the mucus is too thick, again, the cough cannot bring it out. It cannot push it out because it's too thick, and that will lead to ineffective cough. Also, there is basically cilia in our airways. These are small hair-like projections in the lining. Those things, they continually beat upwards so that whatever is pulled in the lungs, they come out through the trachea, the bronchi, and then the trachea. This is called mucociliary clearance. If this mucociliary clearance is also affected, then it can also lead to ineffective cough. As for incidence, 50 to 80% of cancer patients tend to have cough, and with definitely the highest incidence being in lung cancer. So, okay, I made a mistake. It was supposed to be either pathology or pathogenesis. I have mixed the terms, but never mind. It is caused by mechanical or chemical stimulation. That is, something is stimulating the cough center in your brain. Let it be dust particles, let it be accumulated mucus. Maybe it's a cancer tumor. There's a actual lesion in there which the body is trying to get rid of. And to these, the sensation of the foreign body is carried out by myelinated stretch receptors and C fibers that are present in the airway. They are sending the impulse to the brain. And these are innervated by the vagus nerve, the trigeminal nerve, and the phrenic nerves. The axial reflex arc, I'm not going to go into detail. Okay. You've seen the pathogenesis. What are the causes? There are definitely a whole lot of causes because cough is really common. A lot of those I've tried to include in this slide. So basically cardiac and pulmonary, something to do with the heart or the lungs. This can be asthma, it can be COPD, it can be infections. Heart failure can cause cough. Smokers, definitely they have cough. Tracheoesophageal fistulas, that is connection between the esophagus and the trachea, which causes the food particles to go into the lungs, causes the secretions to go into the lungs. Those can cause cough. Tumors in the lungs can cause cough. Esophageal GERD, that is esophageal reflux disease. That is from the stomach, the acid refluxes back into the esophagus. That causes irritation of the lower esophagus, in turn irritating the basically our cough reflex nerves. that leads to cough. This is actually quite a common cause that we see. A lot of patients who have some gastritis picture like that, we tend to have cough and we tend to go another way. But most often, if you treat the GERD, most probably the cough will also reduce. Aspiration. You've all experienced this. You drink water and it accidentally goes into your windpipe and you start coughing. Treatment induced is of note because AC inhibitors, inhalational captopril, drugs like that are commonly used for treating hypertension. Those on prolonged therapy, that is more than 4 weeks, more than a month, if you are using AC inhibitors, it can cause brassy cough. It can cause definitely dry cough. So you have to take a look at that drug chart also. Beta blockers, prolonged use again can lead to cough. Chemotherapy induced. The specific chemotherapy drugs have been mentioned. These are bleomycin, methotrexate, and cyclophosphamide. Use of these specific drugs can lead to cough. Then another drug which is commonly used for UTI is nitrofurantoin. That can also, it's been implicated in causing cough in patients. Radiotherapy by pneumonitis and fibrosis. Okay, so we know the causes. The patient has come again with cough, so we start evaluating. First, second, history. Onset, duration, frequency, associated factors, exacerbating and relieving factors. You ask everything. Specific questions to be asked. Is it wet or dry? Is the cough wet? Is it dry? That is something coming out when you cough. So, what I mentioned before, wet cough is actually, let's say, good. It's physiological and serves a function. And hence, what we have to do is we have to make sure that there is not too much effort in the coughing. You can make sure that we can give some expectorant so that whatever is being tried to be coughed up, that comes out more easily. Dry cough has no such purpose. So what we have to do is we have to suppress it. And when does wet cough become distressing to the patient? Suppose the patient is dying and he is too weak to cough something out. In that case, it is not serving its purpose anymore. Even though the cough is where there is something to cough out, he's not able to because he's so weak. And in such a case, these weak coughs, they are also going to not provide any benefit whatsoever. In such cases, you have to suppress wet cough also. That is in dying patients. Next question you have to ask in history is the cough caused by cancer? Basically, it's obvious if the patient has lung cancer and the patient has chronic irritant cough, you can see by the picture itself. You don't have to do too much evaluation to understand that the cough is being caused because he has a cancer in his lungs. Okay. So in case it is associated with something like wheezing, or if he has a heartburn, he says there's in Malayalam we say irichil. If he has something like that that's described along with cough, that is only the reason for which you have to do further evaluation. Otherwise, cough caused due to cancer is something you can make out only by just looking at the patient and seeing him cough. Next, two questions to be considered. This is not what you ask the patients, but what you think to yourself. Can the cancer be modified? Because if the cancer is causing cough, if the cancer is the cause of cough, can the cancer itself be treated in such a way that the breathlessness can come down? This is essentially not palliation, this is curative efforts that has to be done by the oncologist, not us. Here you can consider radiotherapy or chemotherapy so that if the tumor, there's a change in tumor status, then definitely the cough will be better. So, but these are again not palliative, these are curative efforts. Then can the impact of cancer be modified? That is definitely palliative. Suppose if there is a pleural effusion that is causing cough, there's pleuritis causing cough secondary to pleural effusion, then tapping the pleural fluid, that can provide a relief to the coughing. That is definitely comes under the purview of palliative care. So these are the things we have to consider while taking history. So on to the actual management. Again, we follow the basic principle of initially correcting the correctable, then doing the non-pharmacological aspects, and finally giving drugs. Correct the correctable, obviously it's common to basically everything. You found something out that is causing the cough, you treat it. If the patient is smoking, ask him to stop smoking. After cessation of smoking, if you stop smoking today, it takes around 4 to 6 weeks so that the coughing stops. That's a window period that it takes to actually see the benefits. If it's asthma or COPD, again, you give the acute inhalational drugs. If it's allergies, you give anti-allergics, antihistamines. If it's infection, you give antibiotics. If it's offending drugs such as AC inhibitors, you switch them over to something that is a bit more usable. If it's AC inhibitors, he's on, switch them to ARBs, losartan or telmisartan, stuff like that from unilateral gap total. These are all things that you can do if you find a cause that can be corrected. Next is non-pharmacological management. Specifically for coughs, it's not as huge a role as for it had for breathlessness. Here, basically, what you have to consider is coughing should be efficient for it to be actually serve its purpose. If you're lying down on your bed, you're coughing against gravity. Something has to come up against gravity, and that is basically inefficient. If you're coughing, if you're having a coughing bout, it is better to sit up so that whatever is coming up can actually go out. Chest physio. This has to be discussed with your physiatry team. If you have a physiotherapy team available, advise them to do chest physio. What it involves is you give a gentle pulsing massage from down upwards so that whatever expectation is, you can sort of tap it upwards so that it's easier to cough out. Steam inhalation. This is what we classically do when we have a cold. Just take a steam bath. That can help. Forced expiration from a low to medium lung volume. That is, we told that the cough is forced expiration. You ask the patient to take half a breath. You ask them to forcefully exhale it out. This is basically simulating a cough without actually coughing. It's a sort of a halfway cough so that it helps to clear the airways so that they don't have to cough so much. There's something that can be attempted, but the efficacy of it is questionable. And then assisted cough maneuvers, I haven't seen it being done on a regular basis. It's similar to Heimlich's maneuver. You apply pressure over the lower chest and the upper abdomen, sort of upward, so that the patient, while he coughs, there's a bit more pressure. It's not very well tolerated, so that remains to be seen. But definitely, this forced expiration can be attempted. So the mainstay is obviously going to be in cough, it's going to be drug therapy. For wet cough specifically, what I mentioned was we have to give expectorants. Only in the dining case are we giving antitussives. In wet cough, in an otherwise okay patient with relatively okay prognosis for a long period, we can give expectorants. What can we use this? You give saline nebulizations, 0.9%, 2.5 ml, put it in the nebulizer machine and give it maybe once, twice, or up to 4 times a day, or also on a SOS basis can be given, and that can help with cough. You can give mucolytics because in case the mucus is too thick to come out, you can give irritant or chemical mucolytics. I personally have not seen irritant mucolytics being used. Chemical mucolytics definitely. N-acetylcysteine is commonly used. It's I think brand names available are Mucinex, Palmoclave, Broclear, stuff like that. That you can definitely use. Pure N-acetylcysteine, it's available as 600 milligram tablets. You prescribe it for twice daily for a week and see if there is any change. Physicians and pulmonologists, they tend to use nebulized hypertonic saline. The usual saline is 0.9%. This is 3 to 7%. They give nebulizations of it. Again, it is supposed to provide with some mucolytic effect also. Dry cough. This is the pathological cough for which we have to actually suppress the cough. Antitussives are used. Antitussives can broadly be classified as two types. One is the peripherally acting demulcents and the centrally acting opioids. We have to start with demulcents, and then you can add an opioid later if it's required. Demulcents that are commonly used is basically if you buy any cough syrup today, it's not just one ingredient. There are a few things in it, and one of those things is always going to be a demulcent, and commonly includes glycerin, methyl cellulose, propylene glycol. Next time you see a cough syrup bottle, take a look what the demulcent component of it is, and you give this. And in case there is no relief with it, then you can add a opioid to it. Usually we have morphine commonly available. That's why morphine is a prime example. 2.5 to 5 milligram, 6 to 4 tally can be given, and to increase the dose as necessary. The issue with opioids is it is effective for cough suppression as long as it's coming from lower down. If it's an upper respiratory tract issue, some obstruction or an infection in the upper respiratory tract, morphine and opioids in general tend to be not as effective. That you have to keep in mind. If the cough relief is unsatisfactory with opioids, then you can try some other reserve drugs. These are not commonly used. These include gabapentinoids, sodium chromoglycate in inhaled form. You can give benzodiazepines also. That is, it is for specifically indicated in lung mets cough, but none of these are, we don't see them being used on a regular basis for the treatment of coughs. Okay, so that was all regarding coughs. And the final major symptom I'll be discussing that we can include in palliative care is hiccups. It's actually quite common. What it is it's a spontaneous myoclonic contraction of the diaphragm. That is suddenly the diaphragm that's supposed to be here and it slowly inhales, it goes flattened, it goes down immediately. So there's a sudden inhalation of air. The issue is it's also associated with there is a thing called the epiglottis, which protects our windpipe basically. It's shut suddenly when the diaphragm flattens. That is what gives it that that characteristic sound, that sudden inhalation and a sudden stop. That is a hiccup. So it's generally transient. We don't, in general practice, we don't usually see patients who have a prolonged hiccups, but in palliative care, it's supposed to be transient when it lasts for less than 2 days. We commonly don't see patients that have been having hiccups for 2 days at a time, but less than 2 days is considered to be transient. If it lasts for up to a month, it's considered to be persistent. And if it's more than a month, it's intractable. What it can lead to includes disturbed sleep due to hiccups. If you have disturbed sleep, you've become exhausted, and the disease condition versus the reflex involved. Again, just a short explanation. It's what causes the sensation that carries the impulse to the brain. Those are carried by the phrenic nerve, the vagal nerve, and the sympathetic nervous systems. That is what takes the reflex to the brain. In the brain, the center where the hiccups are controlled, it's located, it's a diffuse area. It involves the midbrain, the brain stem, and the spinal cord, the proximal part of the spinal cord in the cervix, in the neck. That is what is involved in the hiccup center. And the impulse to actually have the hiccup, that is carried to the body by the phrenic, intercostal, and vagal nerves. Some of the causes of hiccups have been mentioned here. Some will appear as a surprise. Patients with seizures can have hiccups. Multiple sclerosis, it's a progressive nerve degeneration disease, can cause hiccups. Stroke patients, that because of the lesions in the brain, they can have hiccups. Trauma cases, tumors in the brain can cause hiccups. Goiter, patients with hypothyroidism, if they have a neck swelling, the phrenic nerve and vagus nerve all pass through the neck, those patients can have hiccups, intractable hiccups. A foreign body in the ear, maybe an insect goes into the ear or a flower, kids tend to put it in, and if it lies on your eardrum and irritates it, that can cause hiccups because the nerve supply is the same. And abdominal causes, these are the most common. Gastric distension, basically gastritis, patients say they have gastroesophageal reflux disease. All of these can cause hiccups. Diaphragmatic irritation, phrenic nerve irritation can all cause. Hyperglycemia and hypocapnia. These are, hyperglycemia is pretty common because we are the diabetes capital of the world. Hyperglycemia is a very common finding in our society. So that can be a cause for hiccups also. Alcohol intake, benzodiazepines, and the opioids that we use, they can also cause hiccups. Evaluation. There is not much to evaluate for hiccups per se because patient is having hiccups. You can take a brief history. Okay, when did it start? How is it proceeding? Is it worse? The duration, that is important. Those are things that you can ask, but the thing is, you are seeing the patient having hiccups, you look at the pattern, and you can initiate therapy. The actual history aspect of it gets weaker for hiccups. But in some cases, definitely, in case the patient is having persistent hiccups or intractable hiccups, definitely you can go for some investigations. You can go for X-rays, you can go for esophageal manometry, you can go for endoscopy, stuff like that. That is indicated, but again, it does not come under the purview of palliative care. That is to be done by the specialists, the concerned specialist who can evaluate them further. Management. So, again, correct the correctable, go for non-pharmacological methods, and then finally, drug therapy if everything else fails. Okay, so correcting the correctable, again, I'm not going into too much detail. If it's gastric causes, if it's gastric distension, don't eat too much. Just small frequent feeds can be suggested. Then alcohol, stop drinking. If it's spicy food, stop eating spicy food. Use bland food. Stuff like that. Correct the correctable. Whatever you identify, ask them to modify it or stop it. That is according to your discretion and what you find out. Non-pharmacological management. These are the classic folk medicine that we use. If you have hiccups, you ask them to hold their breath for a while, and the hiccup goes away. You can ask them to breathe into a bag, rebreathe from a bag. That helps in some cases because, as we mentioned, hypocapnia was a cause. So, the breathing into a bag will increase the carbon dioxide in our body. Valsalva maneuver. That is closing your nose and mouth and breathing out forcibly. That can also help with reducing hiccups. Then cold compress, applying cold to the face, massaging a carotid sinus, and then scaring the patient. This has actually proven to have some benefit, but it's questionable at best. Then tongue traction, pulling on the tongue, massaging the junction between the hard palate and the soft palate in your mouth, massaging it with a cotton swab. Then smelling salts, something that we use to wake patients up if they're unconscious, inhaling that, swallowing crushed ice, stuff like this. These are all folklore, but they have proven to have some benefit in managing hiccups. So pharmacological management. Again, this will be based on the cause of the hiccups. We took a look at a lot of it. If it's caused due to gastric distension or if it's due to reflux, then definitely we can go for a prokinetic. Perinom, metoclopramide is the generic name. Perinom is a tablet, 10 milligram. You can give it thrice a day or up to 4 times a day. And for gastritis, you can give Pantop, one tablet in the morning, half hour before food. In case it's not gastric, it's not something peripheral, it's something to do in the brain. If it's centrally acting, we can try giving a muscle relaxant, that is baclofen. The normal dose, baseline dose is supposed to be 10 milligram thrice daily. Anything between 5 to 20 milligram thrice daily can be used. Again, gabapentin is of use here also. It's a centrally acting drug. You can start off with 400 milligram thrice daily, followed by 400 milligram once daily for 3 days. This is called burst gabapentin therapy. It has been proven to be of some benefit in trying to treat persistent or intractable hiccups. Calcium channel blockers, anti-epileptic drugs such as sodium valproate, dopamine agonist, and benzodiazepines. All of these can also be used, but they're all second line. Again, I have not essentially seen them being used yet for treatment of hiccups as such. So that is regarding the pharmacological management of hiccups. So those were the 3 major symptoms that I wanted to discuss with you. There were 2 more, pleural effusion and hemoptysis, which, as I mentioned in the beginning, both of those have very little, let's say, action from palliative care. Those have to be managed by the concerned specialist, by the oncologist as such. What you have to know is basically just to identify it. But more often than not, both pleural effusion as well as hemoptysis, they tend to be evaluated from the physician side, from the oncologist side, from the pulmonologist side, and then they come to you. So that does not hold as much importance as the other 3 symptoms that have been discussed so far, because most of these pleural effusion and hemoptysis will require some skilled things to actually counteract it. The only thing you have to know is hemoptysis, the drug therapy is primary drug is tranexamic acid, the dose is 1 gram thrice daily, and a stat dose of 1.5 as necessary. Just keep that in mind. So those are all the things that I could come up with respiratory symptoms in palliative care. That's all. Thank you.
Thank you, Dr. Ashmal, for the wonderful detailed session. Anybody have any doubts on this, please ask. Any questions?
It's all thank yous. They're all done.
Yeah. We have 5 minutes more, so if you want to ask anything, you can ask. So Sister Anita Rani has agreed to present a patient story today. Unfortunately, she was not able to join today because of some network issues. So today, no case presentation. So they don't have any questions. Hope your class is
It was a bit long, but hopefully something has gone across. That's all I hope.
definitely. So they, I hope they got a good idea about respiratory symptoms, especially I would like to highlight few things because this is one of the most common distressing symptom, um, as well as the patient and the patient family also. So this is a subjective experience. We had learned many things today. You have to assess properly and treat the underlying cause. Uh, Always go with the non-pharmacological management, and then you can move on to the pharmacological management also. As much as possible, be with the patient and just to tell them you are not alone. We are here to take care of you. So that message you have to convey with the patient and the family. So this is one of the most distressing symptoms. So all other points, Dr. Ajmal has clear that taught us clearly. So I don't want to repeat again. Uh, Anybody wants to add anything? Dr. Ajmal, can we conclude?
Sure.
Can we, when?
I'm done.
Yeah, okay, actually, okay.
Yeah, thank you, Dr. Ajmal, for the wonderful session, and thank you, Sister Shiba, also, and thank you once again to all of the joins who have joined us. So, see you all in the next session. Thank you all. Thank you.